Disease modifying antirheumatic drugs. Disease modifying antirheumatic drugs DMARDs are a group of small molecule inhibitors of the immune response. They are employed in a range of inflammatory rheumatic diseases as well as in other chronic inflammatory conditions. Most of these drugs have the potential to cause bone marrow suppression or liver dysfunction, and they require regular blood monitoring. Monitoring requirements for commonly used DMARDs are also summarized in box 2434. If toxicity occurs, treatment may need to be stopped temporarily and resumed at a lower dose. If toxicity is severe, therapy may have to be withdrawn completely and another drug substituted. Methotrexate. Methotrexate is the core DMARD in rheumatoid arthritis, juvenile idiopathic arthritis, and psoriatic arthritis. It inhibits folic acid reductase, preventing formation of tetrahydrofolate, which is necessary for DNA synthesis in leukocytes and other cells. It is given orally in a starting dose of 10 to 15 mg weekly and escalated in 2.5 mg increments every 2 to 4 weeks to a maximum of 25 mg weekly until benefit or toxicity occurs. Folic acid 5 mg per week should be co-prescribed to be taken the day after methotrexate, since it reduces adverse effects without impairing efficacy. Benefit is usually observed after 4 to 8 weeks, but treatment should continue for 3 weeks before the conclusion is reached that MTX has been ineffective. The most common adverse effects are nausea, vomiting, and malaise, which usually occur 1 to 2 days after the weekly dose. Individuals who experience these effects can sometimes be successfully treated with subcutaneous methotrexate. Patients should be warned of drug interaction with sulfonamides and the importance of avoiding excess alcohol, which enhances methotrexate hepatotoxicity. Acute pulmonary toxicity, pneumonitis, is rare but can occur at any time during treatment, and patients should be warned to stop therapy and seek advice if they develop any new respiratory symptoms. If pneumonitis occurs, treatment should be withdrawn and high dose glucocorticoids given. MTX must be co-prescribed with robust contraception in women of childbearing potential, and treatment must be stopped for 3 months in advance of planning a pregnancy. Sulfasalazine. Sulfasalazine can be used alone or in combination with methotrexate and other DMARD. Its mechanism of action is incompletely understood. Nausea and gastrointestinal intolerance are the main adverse effects, but leukopenia, abnormal liver function test, and rashes may also occur. The usual starting dose is 500 mg daily, escalating in 500 mg increments every 2 weeks to a maintenance dose of 2 to 4 gram daily until benefit or toxicity occurs. Benefit may be observed after 4 to 8 weeks, but treatment should be continued for 3 months before the conclusion is reached that it has been ineffective. Orange staining of urine and contact lenses may occur. Here the box showing disease modifying antirheumatic drugs. Methotrexate maintenance dose 10 to 25 mg weekly orally. Monitoring is full blood count and liver function tests. Indication rheumatoid arthritis, psoriatic arthritis, ankylosing spondyloarthritis, JIA. Sulfasalazine 2 to 4 gram daily orally. Monitoring is full blood count and liver function test. Indication is rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, and JIA. Hydroxychloroquine maintenance dose 200 to 400 mg daily orally. Monitoring is visual function. Indication rheumatoid arthritis SLE. Leflunomide 10 to 20 mg daily orally. Monitoring is full blood count, liver function test, and blood pressure. Indication rheumatoid arthritis, JIA, psoriatic arthritis. Azathioprine maintenance dose 1 to 2.5 mg per kg daily orally. Monitoring is full blood count and liver function test. Indication SLE and SV. Apremilast maintenance is 30 mg twice daily orally. Indication psoriatic arthritis. Tofacitinib 5 mg twice daily orally. Monitoring is full blood count, liver function test, infection. Indication rheumatoid arthritis. Baricitinib 2 to 4 mg daily orally. Monitoring is full blood count, liver function test, and infection. Indication rheumatoid arthritis. Cyclophosphamide maintenance dose 2 mg per kg daily orally or 15 mg per kg IV. Monitoring full blood count, liver function test, and EGFR. Indication SLE and SV. Mycophenolate mofetil maintenance dose 2 to 4 gram daily orally. Monitoring is full blood count and liver function test. Indication SLE and SV. Gold myocretin 50 mg 4 weekly IM. Monitoring is full blood count and urinalysis. Indication rheumatoid arthritis. Penicillamine 500 to 1500 mg daily orally. Monitoring is full blood count, liver function test, and urinalysis. Indication rheumatoid arthritis. Cyclosporin A maintenance dose 3 to 5 mg per kg daily orally. Monitoring is blood pressure and EGFR. Indication is rheumatoid arthritis and psoriatic arthritis. Monitoring tests are usually done every 2 weeks on initiation of treatment for 6 weeks, then monthly for 3 months, then 3 monthly. Now, hydroxychloroquine. Hydroxychloroquine is used in the treatment of rheumatoid arthritis and SLE in a dose of 200 to 400 mg daily. Its mechanism of action is incompletely understood. A wide range of side effects can potentially occur, but hydroxychloroquine is usually well tolerated in practice. With long-term use, there is a risk of ocular toxicity due to accumulation in the retina. Although this is uncommon, it is usual to check visual function before starting treatment and to repeat this periodically while treatment is continued. Hydroxychloroquine is generally considered to be safe during pregnancy. Leflunomide. Leflunomide can be used alone or in combination with other drugs in a dose of 10 to 20 mg per day. It works by inhibiting dihydroorotate dehydrogenase, an enzyme used by activated lymphocytes to synthesize pyrimidines necessary for DNA synthesis. It has low merotoxicity but may cause liver dysfunction, hypertension, and hirsutism. It must be co-prescribed with robust contraception in women of childbearing potential. Treatment must be stopped for a period of 2 years in advance of planning a pregnancy. Now, azathioprine. Azathioprine is most commonly used in vasculitis and SLE. It is metabolized to 6-mercaptopurine, which blocks lymphocyte proliferation by inhibiting DNA synthesis. The typical starting dose is 1 mg per kg body weight per day, increasing to 2.5 mg per kg until a response is observed or toxicity occurs. Bone marrow suppression is the most important side effect, but nausea may also occur. Genetic polymorphisms in the enzyme thiopurine S-methyltransferase (TPMT) influence catabolism of 6-MP, and sometimes genetic testing for TPMT variants is done to guide doses. Allopurinol inhibits catabolism of azathioprine, necessitating a 75% reduction in azathioprine dose. Apremilast. Apremilast is used in the treatment of psoriatic arthritis. It works by inhibiting phosphodiesterase D4 in leukocytes, which in turn suppresses production of pro-inflammatory cytokines, thereby reducing inflammation. Apremilast is given orally in a dose of 30 mg twice daily. The main adverse effects are gastrointestinal upset, weight loss, and an increased risk of depression. Now, Janus kinase inhibitors. Janus activated kinase JAK inhibitors work by inhibiting JAK enzymes, which are a family of intracellular signaling molecules that play a key role in transducing the effects of several pro-inflammatory cytokines. They are indicated for patients with rheumatoid arthritis who have responded inadequately to standard DMARDs and provide an alternative to biologic treatments. 2 JAK inhibitors are currently available: tofacitinib, which is given orally in a dose of 5 mg twice daily, and baricitinib, which is given orally in a dose of 2 to 4 mg once daily. The main adverse effects are an increased risk of opportunistic infections, hepatotoxicity, and hematological toxicity. Now, cyclophosphamide. Cyclophosphamide is a cytotoxic alkylating agent that cross-links DNA and halts cell division, causing immunosuppression. It is mainly used to induce remission in life-threatening systemic vasculitis and SLE. It can be given orally in a dose of 2 mg per kg day for 3 to 6 monthly, or intravenously in a dose of 15 mg per kg every 3 to 4 weeks on 6 to 8 occasions. Adverse effects include nausea, anorexia, vomiting, bone marrow suppression, cardiac toxicity, alopecia, hemorrhagic cystitis. The risk of cystitis can be mitigated by co-administration of mesna, 2-mercaptopurine, 2-mercaptophin sulfonate, which binds its urotoxic metabolites, and a high fluid intake.